Honorable Commissioner for Health, Dr. Vincent Okpala, members of the Governor's Media Team, GMG, and of course, staff of the Ministry of Health here present. On behalf of the Chief Press Secretary, who is the brain behind the Media Group and this event, I welcome you all formally to today's event. Honorable Commissioner, the idea of Meet the Media came from the need for properly managed information about the functions of various ministries, agencies, and parastatals of government. Even though almost all the members of this media team are appointees of government, we may not claim to know every detail about things that the ministries are doing, and therefore may not be in the right position to disseminate information adequately to the public so that they know the inner workings of various ministries, agencies, and parastatals of government. But overall, we see the success that is being achieved. Therefore, the idea of this meeting is a very friendly, relaxed, brotherly, and sisterly atmosphere where you feel free to let us into the inner workings of your ministry. We know that with the COVID-19 pandemic, your ministry and yourself have been in the forefront of the fight to control the spread. But even before then, we knew that a lot was happening in the ministry. Therefore, what you have here is a very friendly press. It's usually you will give us a short, brief opening remark, after which the microphone will now go to the Chief Press Secretary, after him, the Deputy, and then we go to members for questions.
CPS, to His Excellency, to James Cesar, and the Deputy CPS, Honorable Emeka Ozunga, and all the members of the media here present. Thank you. I'm really appreciative and honored to have this kind of forum put together by the media. It shows how I've always respected the work that the media team of His Excellency does, and very proactive, very creative, and ingenious. So this is quite good. Now, with respect to the health ministry, at the inception of this administration in 2014, there were things that were met on ground, and it's on record that His Excellency set a vision. His vision for the state was built on 6 pillars and 15 enablers, and health was one of those 15 enablers. And His Excellency Chief Dr. William Obiano went ahead and created a blueprint for health, a 24-point blueprint based on this enabling role of healthcare industry in the state with respect to what he envisioned for the state. This 24-point blueprint was actually built on the 6 building blocks for health. The acceptable 6 building blocks. WHO established 6 building blocks for a health system. Looking back, we see that a lot of these checkpoints, if you organize them as checkbox, have been ticked off on, and it's still work in progress. And I believe by the time we get to the finish line, we look back, we will be like 99.99% complete in those blueprints that were outlined by His Excellency. Unfortunately, this year redefined healthcare for the world, especially in Nigeria and more especially in Anambra State.
So we would like to ask you more pointedly, what specifically has the experience been for you and for Anambra State so far in the fight against COVID-19?
The experience about COVID-19 in Anambra State is not a personal one. It's an experience that actually I've lived through, continue to live through with the media team. I look at every face here, you are all part of that story. And when we discuss the high moments we rode that wave together. When we discussed the low moments, we took that trough together. But going back, when January 2020 clicked the first, nobody knew what we had in play. As a matter of fact, rewinding like 2 months before that date, the Ministry of Health had their first annual operational plan, the first time that is happening in the ministry. And what does this mean? Basically, we laid out a ground rule of how we want to run from January 1 to December 31, 2020. So it was a big event for us. We attracted the sponsorship of European Union and WHO for that event. It was a 1 to 2 weeks event. So basically, we have a strategic plan, 5-year strategic plan. Then the AOP, annual operation plan, was supposed to be an annual thing after having the 5-year strategic plan. So every year you slice a 1-year cut and then establish what you're going to do for the year. So we did this exercise in November, and we were waiting for our AOP validation. We need to validate what we agreed upon. Every unit in the ministry brought out what they wanted to do. It's not just a plan of what they want to do, it's actually a costed plan. So, and then a time plan. So by June 1, you ask me where everybody in the ministry is going to be, I'm going to tell you that they're going to be in so and so place, doing so and so thing, 2020. So that was the plan. So you see how that hit us. So we already had a plan laid out, how 2020 was going to run. But that actually shows the parochial nature of man. So by 1st of January, we started hearing things about Wuhan. Then we were thinking, okay, it's just going to be in Wuhan. It's not going to come over to this place. Then by January 14th, Lassa fever hit. Already Lassa started around Nigeria around November, December. By January 14th, it hit Anambra State. We had a first case. Now, with that first case, we started shifting. Our AOP validation was supposed to be around that week. And we're like, okay, what's going on? Our rapid response team was put together. The rapid response team actually is one of the achievements of this administration. So this is a team of a multi-sectorial or interministerial team of individuals that want to contribute anytime we have an emergency. We have a slice from health, education, agriculture, environment, and what have you. So this team has been reporting to teams like when we had the flooding last year. This was the team that went to all the locations and did what they had to do. So this team came together. Our emergency operations center was opened. This center also is one of our achievements of this administration. So they came together. They had the index case for Lassa fever and started working on the Lassa. And once you are open, you have to keep on doing contact tracing, doing all the things you do till you give a number of weeks. If you don't have any positive case, you can say, okay, I think we're good to go. So while we are still working on Lassa, by January 30, we went on our last status for coronavirus. Then it was not yet a pandemic. WHO was still debating whether to call this a pandemic or epidemic. But that kept on going, and we were telling ourselves, our people are well traveled. They are in Guangzhou. So to me, actually, it could be breakfast in Guangzhou, dinner in Atman Market. So, and we have such hardworking group of people. So you expect that if something is happening in China, if they sneeze in China, we might catch a cold in Anambra State. So then we didn't have the index case in Nigeria yet, the one that came to Lagos. And we realized that, okay, we have to go into the mode, the different stages of public health emergency response. We went into the stage of mitigation. We realized that this country does not have what it takes to respond to this adequately, based on what we saw happening in the developed economies, developed health systems like China, Italy, United States of America. So the preaching then, our message then was that we have to put our strength and energy where we have comparative advantage, and that was in mitigation. And when we discussed these 4 stages, you go through mitigation to preparedness. From preparedness, you go to response. From response, you go to recovery. So right through that mitigation, a lot of things we are done in the States. It was a learning curve for everybody, it's a new disease. From there, I went to the stage of preparedness. His Excellency was the Commander-in-Chief for this disease, the Field Marshal for the fight against COVID. A multi-sectorial interstate team was set up in Anambra State. It would just help people not just from health, but from other ministries, not just from other ministries, but also from beyond the state. It showed the seriousness of the government towards the disease that was coming down. The preparedness showed that the way we got prepared for this was stellar. And from there we went into the response stage. And the result of that is there to be seen for everybody. And that is, it's been a learning curve for all of us. And there's had a lot of teachable moments. Had a lot of moments that we will say, oh, wow, what is going on, you know? And one thing that COVID-19 has done for everybody is that it became a teacher. It became a humbler. Great economists were brought to their knees. Professors became students. Everybody was learning. And the good thing about what happened actually with respect to COVID was that in this state, the state saw a lot of leadership, very strong leadership from His Excellency. You know, in things like the use of face masks, making it a law for people to wear face masks. Before even CDC in America agreed, WHO, that the use of face masks, cloth face masks, should be done for everybody. This state already has moved on cloth face masks. So that was a first, even before the country said, okay, this was the right thing to do. So looking back, evaluating what has happened, I'll tell you that we regret the lives that were lost all over the globe, even in Anambra State. But if the interventions that were made were not made, it would have been worse. So we thank His Excellency for his leadership. We thank God above all for giving us somebody like His Excellency to be at the helm of affairs at this point in time. It could have been a very sad story, given how healthcare has been in the state before this administration. Thank you.
On COVID-19, a lot of Anambra have complained that when they call the emergency numbers provided by the task force team, that they usually don't answer them. That's one. Two, some persons complain that the governor proactively built isolation centers across the 3 senatorial zones in Anambra State. But often, we'll brief in the Anambra that the COVID-19 patients that we have in Anambra are being treated in their homes. So they now wonder, those that are being treated in their homes, are they being treated by the government or by themselves?
With respect to unanswered calls, it's regrettable to hear that, but what also is true is that most of the responses that we've gotten are from those calls too. You know, so we've had multiple responses since the onset of this pandemic. As a matter of fact, when people say that things don't work, mine actually is not to say they are not telling us the truth. I like to investigate everything. In fact, main reason why we have an emergency operations center, one of the things the calls, we don't call it call centers, we call them events and rumors. Every call is evaluated based on its merit. Recall that before the index case in April 10th, the Ministry of Health, the rapid response team, responded to a number of calls leading to placing 5 different groups in quarantine, and eventually all of them were evaluated and adjudged to not have the disease after 14 days. How did we learn about them? It's through phone calls, you know. So there was a time we changed our numbers and we communicate those new numbers to people. So sometimes equally what I see happen is that some people have those old numbers, but above all, what also has happened is that people will go and Google NCDC number, and then we call Abuja and not Anambra State. As a matter, if you remember our index case, the report from the hospital was that they called NCDC and the NCDC person responded after a day or two. We do not have NCDC in Anambra State. We have is Ministry of Health. So when they call NCDC, because they are very busy in Abuja, sometimes it takes me a day or two to get us to know about it. So calls are usually answered if they call a number. That is the main information. And then also, when we look at our daily stats that we report, like when you look here, you notice that one of the cells shows the telephone sign with today has a number 16. It shows that yesterday we received 16 calls. And out of these 16 calls, 5 were escalated. But that means they got a call, they validated that call, because calls can be for anything. Some people call and say, is there still COVID-19? I say, yeah, there's still COVID-19. That's the call. It gets recorded as an event, you know. And then they choose the ones to escalate based on the discussion. They don't keep anything they don't have to keep. So that team is a robust activity that has been active since January 14th. And these are actually civil servants. When I call these guys by 3 a.m., they're up and about. You say, I need to go to Asia Glow to 3 a.m. My drivers are moving, the epidemiologist is moving, the members of rapid response team are moving. So I really commend them a lot. That is one. Then the other one is about the treatment. This is a science. The response to COVID-19 is a science. So you evaluate situations, you respond to situations. Okay? There are no dogmas here. So now what has happened is that what you get from NCDC and WHO are mostly guidelines. Like I said, COVID-19 is a humbler, and what it has done also is a leveler. Everybody is a student at this point. So we studied Anambra State and said, what is peculiar to our people? What do we need to do right to get things right? Yeah. So we developed a lot of things, like our ASCOT tool, the screening tool that we use to start placing people on treatment or leading them to testing. This was where the place started in the country. So we developed that. That helped us save a lot of lives. A lot of lives. Now that is one. Two, we realized that when we started testing aggressively, when I ask people, Anambrarians, you having symptoms, you need to get tested. The person tells you, I don't want to get tested. So why don't I want to get tested? I don't want them to put me in the protective care center. So why are you afraid of protective care center? I don't want to stay away for 2 weeks. I've been to the market. I've spoken to members of the COVID-19 task force team that we trained across the market, across the 326 political wards. I keep on getting the same answer. I do not want to go to the center. And why don't I want to go to the center? Because they send media stuff. They don't realize that that center actually is very comfortable. It was built well by His Excellency. But there's nowhere like home. They'll try to make that place at least feel like home. So the few people, we've had situations where people were positive, and we coerced them that they must have to go to the center. And they eventually agreed after saying we're not going. They went in there, 2 weeks at the point of discharge, they said, I'm not going home, let me stay 1 more week. You don't have any more symptoms, and please, I'm still having some small headache. So you allow them like 2 extra days, because they are very comfortable. They have their DSTV, they have their cable, they have their individual rooms. A few of you have visited that center. You have room, it's built world class, you know. So, but you need to start convincing every Anambrarian, and it's not something that we can achieve. We've actually tried. So when we stated that there was a problem, what did they do? We looked at the whole treatment option. If you're asymptomatic, you don't have any symptoms of the disease, and they evaluate you, you are saturating, your pulse oximeter, you are saturating well. Your saturation shows that your lung is exchanging oxygen with the air very adequately. And then I see you don't have any symptoms. So I wouldn't have to force you to go to the protective care center, especially at the points where we now have community transmission. You know, so what we do in that situation is to start experimenting with country. For those that say, I really don't want to go to the center, and they are emphatic about it, and we didn't want to violate their rights, their human rights, by forcing them to go to the center. So we said, do we have to leave them alone? No. So what do? Treat them. So that was when we started that. And the treatment they get is our own treatment. The His Excellency graciously approved the procurement of medications for this way back in April, first week of April, last week of March. We got medications. So we have a home pack emblazoned with Anambra's logo. So we give that to that individual. We also say there are conditions for you to qualify for home treatment. If you are saturating 90% or low, you can't be home. We will do everything we can to put out. And we've not yet had anyone that tested positive in this state that actually was saturated, that had hypoxia. Hypoxia is low oxygen saturation, that we left at home. That was symptomatic, having symptoms that were concerning. Because they classify that disease as mild, moderate, severe. If you're moderate or severe, you're not staying home. If you're mild or asymptomatic, and you insist you want to stay home, we said, okay, no problem. Because we first tried the first few ones, like first 10 or 20 patients on home treatment, the ones that said they wanted to stay home. You must have a phone with access to WhatsApp. You must have a blood pressure monitor, automatic blood pressure monitor. You must have a pulse oximeter, which we actually provide, and the person can actually pay for that. And must have a thermometer that we can provide. Then we give you the home treatment pack. 3 times a day, you must take those vital signs and send it to our WhatsApp, and we take a look. A couple of times a day, we ask you, are you having any symptoms? Are you having cough, shadows? And the answer is no. We monitor you like you are actually in our facility. If we see things going south, we pull you out of home treatment. They've not really had cause to do that. So this person, healing actually takes place better in a home environment, not the hospital. That's actually why you notice some new hospitals overseas. The architectural design is such that it mimics what the home environment. When you enter the hospital space, is a healing space, is a home. So that was why when we saw that working, we said, okay, since it will encourage people to get tested, because the more we test, the less the chances of spreading the disease, and the greater the chances of actually having less adverse outcome. So that was why we embarked on that, the home treatment options.
First of all, what is the state of the arrangement, when we had issue of analysis? One, we would like to know the status of that initial attempt to have a private testing. We also would like you to explain from pandemic to endemic, explain this community transmission with a view to dispelling this notion that maybe COVID has gone, and then so as to encourage people on what to do at this stage of the disease. And then, what is the state of the testing structure we have in our states with respect to Amako and any other place on it?
So, with respect to testing, I want to use this opportunity to dispel one major rumor that was making grounds in the States. One is that now, before the pandemics hit Anambra State, before our index case on April 10, it's actually on record. By last week of March, we were already discussing with His Excellency about our testing ability. If this makes a landfall in Anambra today, how do we test? And we identified Amako, Chukwuemeka Odumojukwu University Teaching Hospital, as one of the places that has the capacity. They have an Abbott machine, a monster in all regards. They have 5 of those. It's actually the center that handles all our HIV testings in the southeast. And as of today, actually, they've even increased that to even include places like Bini and Ibadan. We are getting samples from other places for HIV right now, CDC, CD4 count. So it's a big center. Now, NCDC or Abbott, they've got the capacity to test for COVID-19. Now, when we realized that they could do that, we reached out to Abbott and said, what do we do? Can we get these test kits? But we were too early because we thought it was going to be easy. His Excellency gave us the directive. Reach out to everybody you can reach out to. We need to have a test capacity. We need to develop that in the state. And we started reaching out. And we suddenly realized what was going on, that this was not an easy task, because we reached out to Abbott. I reached out to people in the US that actually could get us this capacity. And they told us, listen, this thing is not yet available, and if it gets available, everything is controlled by NCDC. NCDC will give you the test kits. So we ran into a wall, and we reached out immediately to NCDC and said, we need to have diagnostic ability in the states for COVID-19. And they came on board almost immediately, but unfortunately they have a limit too. They don't have the test kits in the country, because that system the test kit is specific to Abbott machines. You can't use any other test kit on that machine. Compare this to other systems that they say is open, where you can use any type of test kit on their machine. And we cannot just suddenly throw away this big machine that we have because we want to get an open system immediately. So they kept on promising us that something is coming. Take your samples to other states. We said no problem. We can't stop testing. We have to keep on testing. So that was the first thing. The state did not go to sleep on that. We were always every day on NCDC and always looking for options beyond NCDC, but it wasn't working. The first set of test kits that were made out there, we were fighting a pandemic where the international community also was involved in. So they needed testing too. So we were competing with them. And we don't have that capacity to win that battle against them. But that's it. Now with respect to Acunalysis. For Acunalysis to actually attain their status, they were not the first private test center in the country. The first one was actually in Kaduna. So we were together because they needed an okay from the states for them to be able to test. They cannot buy test kits. Test kits has to still come from NCDC to the states, and the states will now bequeath it to them. So they should not be charging any money for testing. But their private concern, they will need money to keep their lab open. They need money to pay their staff. They need money to certain other reagents that NCDC are not going to be providing. They need money for PPEs and others, So this adds up. The street value of that testing is between 20 to 30,000 naira, on their own system. So there were things that we need to be paying for, But that being said, that was not also the main issue. The main issue also became that at the point they started testing, we got a few sample test kits from NCDC for them. When those test kits came, we saw they don't have some other components that they need to conduct testing. One of those is called extraction kit. So, and it wasn't supplied by NCDC at that point. So when we went there, they still wanted money from the patients for extraction kit. So we see it wasn't going to truly work, So we were going back and forth to help solve those problems before we now got our place activated. But so that was the situation with Acunalysis, and then still on testing, when Amaco started working, we got only 470 kits from NCDC. The country actually got only 1,000 test kits, and these 1,000 test kits, it came from partners to NCDC. NCDC split it between Juku University of Bamako, Makurdi, and Akwebo, the three centers that has this type of machine, abort machine. Yeah. So, and we got a line share. We got 470. So, and once Amako kicked off, we ran through that within 1 week. It was finished. And we were back to square one. Now, the next thing for us was that, how do we get these test kits more than? We can't go to the open market to buy them. So we still on NCDC. We understand that has been procured by partners abroad. But the partners must be the ones to bring it into the country. And there are still some logistic issues here stay there. And we can't just come in and say, take money, do that. They will not agree. But one thing we have done too, we did not just sit back on our ass and say, oh, let's just fold up and, turn around. So we went ahead and started working on proving that our secondary healthcare system can also conduct these tests. That was the key. So we started exploring other test options, like testing on Gene Expert platform. So the Gene Expert machine is that machine that helps in diagnosing for tuberculosis. We have 9 of them in the state, 9 centers in the state, spread across. It's been there. And they've been working, it's well run by the ministry, So now, it was sometimes, when we're exploring the option of using abort, we got wins that the Gene Expert machine can also test for COVID. That was when they were developing it. So we reached out overseas also to them at the same time. And they said, okay, we are still early on this, It took a while, eventually, we were following them until it came into the country. And when it came in, we already were lobbying Abuja, we needed to have the capacity in the state. And that's also I say it has to be in a secondary healthcare facility. Because if this disease becomes an endemic disease, we want our people to have the capacity to test it in even the primary healthcare center, not just in the tertiary institution, And there we are really worried. They're like, General Hospital, you think they can do that? And like, in Anambra State, we are built differently. It will work. His Excellency is on top of this game. It will work. There we are doubtful. So now, our Gene Expert size, for you to be able to have the capacity to test for COVID, you need some new infusion of things. One of them is having what we call a BSL-2 or BSL-3 cabinet, Biosafety Level 2 or Level 3 cabinet. So no Gene Expert sites in the state have that. Many Gene Expert sites in the country don't have that. Maybe just a small handful. You don't need that BSL cabinet to test for tuberculosis. But for COVID, you need that. It's just a safety cabinet. So it does spread the disease all over the place. If you recall that there was a state in the north where a lot of lab personnel came down with the disease, it's because they had a malfunctioning biosafety level 2 cabinet. So I reached out to His Excellency. we need this cabinet, we need a few more things in that site to make this thing work. And he graciously approved that. We got the cabinet into Onitsha and got the few more things that they needed. We chose General to Onitsha and got those things in there, and boom, like 2-3 weeks ago, we got activated on the GeneXpert platform to test for COVID, being the first and to date the only secondary healthcare system in the country that has that ability to test for COVID-19. The only general hospital right now, if you can log into an NCDC microsite, you see that I think there are 64 as of today, 64 test centers in the country. General Hospital is the only general hospital that's listed there. Everything is tertiary institution, specialist hospital, or private labs. No general hospital. So, and now, every other person can you do that in our state? And us, we want to get more general hospitals to be able to do this. And we are working with the SNC to see if we can get their safety level 2 cabinets and the other things they need in at least 2 or 3 more places. If we do that, they can actually activate that because we've shown the capacity that can happen. Right now, testing is going on in Onitsha on daily basis since this started 2 weeks ago. And those, God bless their soul, these gentlemen working there, the members of the RRT, the lab personnel there, they're not used to working nights. They go to work down like 5 p.m. and stay there till 9 a.m. in the morning. By 9 a.m. they are giving me the status. Some teething problems, that they make sure that they work and get the results. They are getting creative, they are doing stuff the right way. And that is the kind of capacity we want to build in the state. The only downside with that GeneXpert is that it doesn't have as much capacity as the Abbott machine. While Abbott machine can run 96 tests, spin out 96 tests per run. But that run actually takes 8 hours. The GeneXpert will spin out 4 tests per run. But each run takes 45 minutes to 1 hour. You know? So I can actually send a sample to Onitsha now, and in the next 1 hour 30 minutes they give me a result. So that is the beauty of Onitsha. That is actually why we are so excited about it. So our doctors can actually make a decision immediately, not before. So we send samples to Erua, out of state labs. Initially we had a turnaround time of 2 days. Things were working. After about a week, turnaround time became like 7 to 10 days. Totally out of our control. We had to start waiting because what started happening was that our healthcare providers stopped treating patients. They say, I'm waiting for lab results. So we are not helping them by actually sending those labs because now we cannot control the turnaround time, which takes like 7 to 10 days. Rather, we say, please start treating. So there was a time, there was a law on our testing. There was a law because we noticed that we could not control what was happening outside the state. It takes like 10 days for the results to come back, and then it's making our people die. And we realized also that if you onboard patients onto treatment early enough, the chance of survival increases. But if you're making our healthcare providers not to treat because they're waiting for lab results, and then people start having adverse outcome. So most of these things led to a little bit of law, but now that we have ability and capacity, things are working okay. Thank you.
I'd like you to give us specific details concerning 1, the healthcare infrastructure built or renovated by the state to fight the COVID-19 pandemic. 2, the coverage so far and effectiveness of the sample collection team in the 21 local government areas. The response to testing and the number of people tested so far in Anambra State. And how many patients have we actually treated since the index case and discharged home? Thank you, sir.
So with respect to the healthcare infrastructure that was built by this administration during their preparedness for the fight against COVID-19, now we have spread across the state. There are ones that have already been completed and there are ones that are still ongoing. Okay, it's better to categorize it that way. So completed work will be the Protective Care Center at Umuawolo, Mboku, and this place actually has 250 beds, roughly, okay? But the other thing about that center is that it has the capacity to blow up to 1,000. So that is the good thing about that location. And the concept behind it was going to be a surge center for people that were symptomatic that needed to bring in. But then it was all about facility-based treatment. Nobody was thinking of home treatment. Now, second place is the Protective Care Center Onitsha. And that we call this protective care center, not isolation center, because we thought of stigmatization. His Excellency was like, he was high on that. We have to have a nomenclature that should not be condemned. The concept of Ajofia, Anatufundi, Tolafo should not be in this age and time. So smartly we went with that name, and it resonated well. So the infrastructure in Onitsha was built with the mindset of, if we have real severely sick critical patients, that they could be taken care of in Onitsha. So we developed a 6-bed intensive care unit. And those 6-bed intensive care unit was built with the mindset of a protective care center versus isolation center. What do I mean by that? So it has, each of the rooms has an ante-room, and they have negative pressure extraction fans. It's not really truly negative pressure, but it mimics negative pressure, so that air doesn't leave that room. The patient's containment to come into the hallway, the air goes out, is piped out. So, and also has central oxygen. The first public facility in this state with central oxygen. So that was achieved there. We had a 12-bed surge. It's an overflow. So that 12-bed surge, further down you have a 40-bed step-down unit. So total capacity in Onitsha that was built this time with respect to beds and infrastructure stood at 58. Now, we took every senatorial zone into consideration when this was happening. Every zone was covered. So we go down to Aguleri, Anambra North. We developed capacity at Immaculate Heart Multispecialty Hospital, Aguleri. So that we had a breakout area where we created a protective care center, and then they have a ventilator. They had 10-bed capacity, And then you go to Mweri, still Anambra North. Initially did 60 beds, and then Access Bank came on board, and then added more capacity there. So it's about 120 beds in that place, So with a lot of equipment. Then you come down to the south, you have Ekulobia. Ekulobia also, it was Fidelity Bank. They helped get Ekulobia to put it together, 100-bed capacity, and about that, and with beds and some other medical equipment that were supplied, like stuff for oxygen. A lot of things that supplies oxygen there, and then other instruments that will help. So that place was supposed to also be a surge center, not for very critical patients. Now, you come to the teaching hospitals, the tertiary institutions, then you have Koyut, Amako. Already Koyut had a section that was called out to be a protective care center, and we went in there and just did a few things with respect to hospital medical equipment. At this stage, it's one of those that His Excellency has been approved for us to make that facility be like Onitsha with respect to looking like an intensive care unit, and that is in process. Now, the other part is in Newi. Newi has a 4-bed unit that has been in existence. They don't have a ventilator there, but basically, so that's how we are spread out across the state. But it's not just in having infrastructure. The key work in these things actually is the capacity. You have to have the personnel that is well trained with the right attitude and the right commitment to take care of patients. So that was where the big gap was in, and we invested a lot of energy to make sure that happened. At the beginning of this pandemic, you mentioned the word C, and the healthcare provider takes up the window. So they run away, they close their doors. But we went on that campaign by first week of March. It's on record that is more than a month before our index case. What did he do? As a ministry, we went ahead, we kept on looking at what was happening at NCDC, CDC, and other parts of the world. So we went ahead to develop an algorithm that will help in the healthcare provider to case define a patient. Because we believe, and I still believe, that having an educated healthcare provider gives you a confident healthcare provider. And having a confident healthcare provider increases the chances of survival for the patient. So that was our mission then. So every healthcare provider in this state had that distributed to them in all hospitals, first week of March, before our index case. And I know some people treated it with levity because they never knew that this was going to land, even though the government kept us saying, be prepared, this is coming, this is coming. But eventually, by the time I had an index case and they realized that this has made landfall in the state, then people woke up. They went back to the literature and the things that we've had. We went back to discussions, we went back to teaching and training and retraining. And people started listening. Providers started paying attention. They started learning about what oxygen saturation means for the patient. People will see an oxygen saturation of 30 or 20 and they're not bothered, you know. So we have to wake them up because they're not used to emergencies. But so we build capacity. We build capacity. We start changing the attitude of the physician. So you hear a patient cough now, they don't take off. They say, oh, just come in. I think it could be and they intervene. So it was, the hiatus was filled. With respect to the infrastructure for sample collection, that's the first thing.
Yes.
So we have a rapid response team. What has happened before we decided to give it a better structure is that people we call. So the 3 ways samples can come to us, 3 to 4 ways is we got a call from a healthcare provider who is concerned about a patient. They call us. The rapid response team responds. They go pick a sample. Then we get a call from a concerned individual who thinks that they could have the disease. They call and we respond and pick the sample, or we have them present to a facility or a sample collection point. And the third one is from contacts, the contact of cases that are already been established. So while doing our aggressive contact tracing, we can test people based on if they meet the criteria for testing. So those are the 3 potential results. The 4th one will be volunteers that just feel, I want to be tested, you know, and we ask a few questions and they get tested. Now, that response was a big stretch on our resources, you know, because we can't be everywhere. We try, but we cannot be everywhere. But we still, whatever call we get, collect those samples only. It might be delayed by 12 hours to sometimes 1.5 days. But within 2 days, that sample is collected, you know, especially for those in remote areas. But that being said, so what we now tried to do differently was creating capacity in the 21 local governments. So we went ahead and we trained some trained collectors in each local government. So we trained 42 persons to help us with sample collection. So this is 2 per local government, and we have to identify a hospital in the local government area where you are comfortable staying, so people can respond, can go there and have their samples collected and pick sample collection days. So those individuals have been trained, and we've already identified the hospitals. We're using a few of them for now, but we are in the process of now building the infrastructure in those areas, across the 21 local government areas. We're getting support from NCDC to help make that happen. Once that support comes in, we're going to have sites. Like right now we have names, but we don't have that infrastructure in all the local government areas. If you have in Onitsha South, you have in Onitsha North, you have in Oka South, we have in a few places. So, but the goal will be by the next couple of weeks that every local government sample collection site, we have at least a reasonable infrastructure that the people will go to every morning, know they're going to work, and within a certain period of the day, 8 to 4, people can go there and have their samples collected. And they have their geostars, and then we will pull those samples to test center. We have the logistic network for that to happen. Now, with respect to, so we pulled sample from the 21 local governments already, but it's having that specific local government-based infrastructure that we are in the process of establishing. Now, the other thing we've done also is His Excellency directed us to establish what COVID action team. It's almost like what he did was to localize what we are doing at the state level. We brought it down, cascaded it down to the community level. So every political ward has a 4 to 5% ward COVID action team, made up of the councillors, made up of the WDC chairman, and the youth leader of that ward, the woman leader of that ward, and the rep from the Ministry of Health. The leader of this team is the councillor. And we brought all of them to Oka to train them. We did a training of trainers experience for them, and they cascaded this down to their ward level. So we trained them on the Anambra State COVID-19 risk stratification tool, which we call the ASCOF tool, symptom-based tool. So and the councillors, all of them were on WhatsApp, so they have smartphones. So their job actually is to do household visits and talk to people. If you notice somebody that has symptoms and that's got to, lead them to testing. So we have a social group, a WhatsApp group, where we have 3 WhatsApp groups, one for the north, central, and south. And people are there interacting and listening to them, having questions, and then attending to issues. And those lab personnel that were, sample collection personnel that have already been trained are also in these groups. So you can easily reach out to them if you have somebody that needs their sample to be collected. So this is the network that we have. We are just making it stronger. And with respect to the number tested already, so our total, as of this morning, based on our daily publication, we had 1,643 samples collected. And then the lab this morning reported 2 positive cases. So our total confirmed is 183 as of this morning. And then we have a positivity rate of 13%. The average for the country is 13.9%. And actually, for you to say this is no longer a problem, we want to go below 10%. That is what NCDC is targeting. Now, the case fatality rate continues to decrease, because the more positives we have, and if you're not reporting death, now the better the case fatality rate gets, you know. And then with respect to active cases, as of today we have 34 active cases, and interestingly we have, out of that 34, 18 of them are in our protective care center, and 16 are undergoing home care. So that is the status as of this morning. Thank you.
When COVID-19 struck, the response of Anambra was almost phenomenal. There were all kinds of donations, palliatives from different individuals, different communities responded in different ways. And there were people who responded at the state level, donating funds to the state COVID-19 fund. Questions are being asked about what has become of such donations. Can you provide any illumination on that?
First, I have to say again, thank you to people in the Anambra for the enormous response that the state received, that pouring of support. It was not just in the state, it was across Nigeria. Now, but at home, it was phenomenal. Not just the state, but you also see actors in the state, the corporate organizations that eschewed the spirit of being a good neighbor, corporate neighborliness, you know. As a CSR project, they embarked on this. Now, we saw donations in cash and kind, you know, and this went, and just let's see, right from us, I told the team, I want to be able to account for every dime donated by people, and there must be accountability, So, basically, and that has actually been the watchword in all this. You know, he oversees this account, and we have a number of signatories to that account. It's not something that one person is overseeing. You know, so any expenditure has been made from. So as I said, donation is cash and kind. So the one that are kind, I think some of the palliatives has gone into supporting our people. Give you an instance, we reached out to a bunch of people. One of the groups actually, like the people living with sickle cell disease. You know, they reached out and we supported them from the edible materials that were donated by people. And so applies to many other groups, you know. Now, with respect to the cash donations, like I said, is whatever expenditure has happened to that account has happened through a very transparent process, you know. So, but we're still in the midst of the pandemic, so we can't say this is how these things have, what the status of the account is of now. But we still have, the account is still in the blue, it's not in the red. So okay. That's what I can say. And we're still responding to the pandemic. Okay. Like I told you, the Amako Center is being constructed. And then we're also moving ahead to have an open lab at Amako. You know, so that in future, we have those options of either using the closed system or the open system. It's going to be a beautiful work. And remember, this is not just that lab. The molecular lab that's being established in Amako, the open lab, which ESCO has approved, is not just for COVID. It's for all the hemorrhagic diseases, viral hemorrhagic diseases. And by this I mean Ebola, monkeypox, the Lassa fever, COVID. So we don't have to go to Iru anymore, Bakiliki. So most COVID has helped us build our capacity. So let me ventilate that again about the donations.
Okay.
Accountability, transparency is a watchword. And ultimately, we also want to show tangible achievements with that fund, you know. So, and that's why I said, if you go to Amako, the molecular lab would outlive COVID. And that was, when I mentioned that molecular lab, I discussed the other aspects of diseases that we experience annually that lab will handle. So that's a tangible infrastructure that will be on ground.
Okay.
That is one. Then two, the isolation center at Amako that has been approved by ESCO. If the fund supports a part of that project or all of that project, it will be another tangible project that people can point and say, okay, this actually was part of the outpouring of goodwill that the government experienced. Thank you.
Reopening of schools and international flights will sooner or later come to be. How prepared are we to face what may follow these?
There was a lot of push. People started getting tired of staying at home. Remember with the lockdown? This is a record that actually the administration was forward-thinking. They were not just thinking about the disease. They were thinking about all the consequences of the disease. They thought about the economic angle, the social angle, the health angle. And that actually ties into, I look at this and I say, the doctor behind their name actually, I thought it was an academic doctor, but it turns out to be a medical doctor. You know, why do I say that? It takes, health is not the absence of disease, but actually the presence of wellness, you know, total well-being. So when you think health, you think mental, you think physical, you think social. And these days actually you think economic, you know. So His Excellency, as the #1 doctor of the state, thought about all these things. And that was why we saw the different responses. And it wasn't just the Ministry of Health. There are some of the issues will come up, he says, okay, local government, commissioner from local government, handle that. Our issue will come up, commissioner for environment, handle that. And we understand that there's no I in team, and we play like a team. So, going to schools, the Ministry of Health was consulted before our school resumption. So the discussion was held for at least 2 months. We were discussing safe resumption, safe resumption, safe resumption. Okay? So during many meetings with the Commissioner for Basic Education, we evaluated the school's readiness for resumption. First of all, is preparedness for resumption. So they need to understand what we're dealing with. They need to understand what they need to do for them to be able to resume safely and prevent having incidents in schools. And also they need to understand that they need to be prepared to deal with the incidents when it occurs, because we cannot just wish it away that it will not occur. So all these things were looked at. Okay, so and the school looked at sanitation. Do we have water? Do we have electricity? Do we have the resources to start? So the Ministry of Health evaluated the system, and we decided, okay, one of the things that we did, every school has to have an infirmarian. Okay, and they did that. Bam. Now we said every school has to have an infirmary, sick bay, and they did that. And so every school has to have an infrared thermometer. These are the things you need to do. You need to go to the schools and make sure that every student stays at least 2 meters from each other. The sitting spaces have to observe social distancing rules, and they did that. Not just the students, the staff quarters, the staff offices, the refectory, and in the dormitories. So they quickly, within a couple of weeks, there was a day actually we made a set starting like the next week, and we evaluated and said, oh, you're not ready. They went back, they took care of business, we came back, we reevaluated. So it was a dynamic process. It was a back and forth. And ultimately, we evaluated to be ready, and it started. So they have also an infirmarian Ministry of Health social group, you know, so the WhatsApp group. So we get a call from them. They know the numbers to call. They know what to do once the students have symptoms. They have the ASCOF tool the Anambra State COVID-19 symptom-based risk profession tool. They have those tools. So they know what to do. They know the numbers to call. And we actually have taken calls from the teachers since the final students went back to school. Those were taking away. So it has to be a graded resumption. That's why all of them did not come back to school at the same time. So, but ultimately, others will eventually return back to school. Then, respect to airport opening, it does started gradually. The international ones will open by 29th, right? So, when that happens, it's almost like we had a little bit of, that is the essence of locking all these things up, for people to actually decrease and diminish the transmission, interborder transmission, and also develop the capacity to take care of business. So we weren't at the capacity we were in January. We are better, So we're more prepared, better prepared to deal with whatever is coming in. We don't want it to come, but if they say they're coming, bring it on.
I'm very observant, and I know that some of the data you reeled out earlier, you were looking at something on your phone. Can you tell us the place of technology in managing the pandemic as applied in Anambra State? And secondly, let us also talk about some of the homegrown measures. Some people are clamoring for, can we look at herbal kiosks perhaps? And we know at some point, Nnamdi Ezekwe University, I think the pharmaceutical studies faculty, they came up with this notion that they think they can do something about developing a key, and I'm sure that in other, a lot of other people came up with such. What have we done? Do we have a leadway? How have we pushed some of these local innovators and perhaps people who have an idea on how we can perhaps have a drug from Anambra State that could be a cure for the rest of the world?
I would say actually has done enormously well for us, and it depends on what actually aspect of technology we are looking at. Because the diagnosis we are looking at actually is technology. The communication platforms that we're establishing is new technology. We are not leaving any stone unturned. Now, the ASCOF2, the Anambra State symptom-based COVID-19 risk assessment tool that was developed and spread out across the state was technology. In fact, the most interesting one I'll tell you about actually is in May, during the lockdown. So we said nobody comes into the state with human remains. By human remains, I mean corpses. So there was a block on that. We had that policy that came out that everybody that dies, we have to bury that same day. Don't go to the morgue. So, but anybody coming into the state has to get special clearance from the Ministry of Health, from the Commissioner for Police. So, and every 2 seconds I'm getting a call from somebody. We had, our borders are enormous. Initially, that taught me a lesson on our borders. It was a geography lesson for me. Initially, I thought it was just Amansi, Ihiala, Bridgehead. There's another one, Iseke. No, the other is Ihiala. But eventually, I learned there are 26, 24 borders. Now, these calls kept coming. The border beaters with human remains kept on beating the borders. But there were 2 or 3 major access points. Amansi, Bridgehead. They were the 2, even here I didn't get a lot of traffic with human remains. So we kept on, every 2 seconds you get a call, multiple calls from people. We need to send our people to go and evaluate the human remain, evaluate the people that came with them, and then try to find out if this is a corpse that we are going to take in, or guide them on safe burial. If they come in and they say, this person died from, let's say, congestive failure, and we look at the papers, we make calls, and we're able to clarify that. We confirm also that they have a ready grave for burying that individual. If they don't have a ready grave, then I sign off on them, and then pass it on to the Commissioner for Police, who will now instruct the boys on the street to allow them access. So this happened throughout May, June, and a little bit of beginning of July. So I realized that there was no way to deal with this without getting innovative technology. So how do you confirm that there's a grave ready? You have to send somebody. Let's say that they're coming through Amansi border and they're going to bury that individual at Iseke. So how do you make those confirmations and verify? So what we did was we went and developed a tool, a survey tool. Again, that survey tool, we trained all our men at the border to help us train them on that tool. So once you see anybody coming with human remains, capture the name of the deceased, capture the name of, a lot of details were there. Where they died, date of birth, where they're coming from, how many people accompanying them, the telephone number of the person at the point of burial, have they sent you a picture, a bunch of questions, and then the name of the person, the border they are accessing the state from, and the name of the individual that's taking that information, email and all those things. It was detailed. So, and then if they have people accompanying them, we need their details too, because we might need to screen them or test them or quarantine them. So they get all this information, and once they hit submit, I have it on my phone. So I turn through it like this. It takes me like 30 seconds to 1 minute, I'm done. And then I look at the WhatsApp group that we set up for the whole team across all borders. And they post the picture of the person at Iseke, that by the graveside, having a placard saying his name and date. Because he can go to the internet and pick up a picture and send to me. But if I say name and that day's date, you cannot put tomorrow's date in a picture on the internet or today's date. So I will now evaluate the whole situation, and I will turn it up to the commissioner for police and say grant access. So a process that used to take like sometimes 24 hours to 48 hours was reduced to 3 minutes to 5 minutes. And not only that, the beautiful thing about that process was that by end of May, it's still on my phone, I can show you, I was able to open up the app, and I saw the number of human remains that either traversed Anambra State or got buried in Anambra State, because we also picked where are you heading to. So some of them actually are coming from Benue, traversing in Anambra to head to Owerri, So some are from Anambra State. So by end of April, end of May, in 31 days, I had 450 human remains traversing Anambra State, either terminating in Anambra State or traversing Anambra State. 450. Whenever I ask you, just take a guess what passed through here in May. They say maybe 35, maybe 40. And we say 450, they're like, what? And by middle of June, we had about 600. It's not so it becomes a publishable data. It helps you track things. So that is just one little way technology has helped. We also developed we worked on a contact tracing app. Even before we started publishing that story for publishing. There was a time it went viral that they are tracking you, so but as a state, as early as April, we developed that app, sent it to Google to ratify and put on the store. But at the point we realized that it might not be necessary. Because we decided it's not a party. But that was one of the things that we did with technology. So there are a bunch of things we did with technology, and we can never do enough with technology. We're still working to get more things done with technology. His Excellency's 24-point blueprint on health in 2014. One of those blueprints is medicine, especially a board of traditional medicine. Because we have a lot of smart medics here, tradomeds, and in Igbo, what they call doctors, Obuebule, and after this, I'd find out if you know why they do that. But anyway, so now we have a lot of Obuebules and people doing stuff. Really, for me, healthcare must not be about popping pills, English pills. We also believe that we have ability locally. And just let's recognize that way back, made us one of the points of 24, his blueprints. So, and he went ahead and actually, the ministry went ahead and created a traditional medicine board, which he gradually inaugurated, and the board is active, and had a special advisor on traditional medicine, just to show you the importance he's placed on this. Now, as a ministry, we've gotten a lot of letters from individuals saying that, making claims about different herbal remedies with respect to COVID-19, And whenever we get that, we do not poo-poo it away. We take it, we refer it to the tribal board, and we have the committee sit and evaluate it. We've also had people that came in and told us that they sent in letters seeking to see the commissioner, that they had a special healing for COVID, and that when they touch a COVID patient, the patient gets healed. So those also were entertained. I brought everybody in, Amarum, So they had a team also look at them. Like one of them that had that special healing power also, a member of the team was a psychiatrist, you know. So they did their job and they give me a report, which we actually evaluate based on its merit. Now, related to the medications, we looked at 6 herbal remedies were evaluated. Okay, serious evaluation, and I think 3 to 4 of them scaled through, and they took it to NAFDAC, you know, and that's the process. So that process is still on. Okay, so we're not we take everything seriously. We don't know. Now, with respect to Nandez University, the Department of Pharmacy, there was something that came up in the news then, right? So we have a professor that's the head of the pharmaceutical school. He's very erudite, you know, highly intellectual fellow, and we brought him into part of the COVID-19 team. He's part of the team. So if you know how the team is organized, the COVID-19 action team is organized in pillars. These pillars actually have 5 thematic areas. You know, one of the thematic areas is R&D. So this individual research and development. So he's part of that R&D team. And we've been sharing ideas and all those. And actually, you also remember that Professor Maurice Iwu is a member of our COVID-19 action team. Yeah. And he has actually, I'm not trying to market for him, but he has something that he put together in a tea bag, you know, which a lot of people have been taking. Some people it's just like, and I know what is in it. These are herbal stuff that some of them are even in your compound, you know. It's not like supplement, but some of these, they are bitters. Bitters are most of the things that we take that bitter, like bitter cola, garcinia, guava, king of bitters, and you have a bunch of them. When you take those, the alkaloids, they are known to jazz up your immune system. They're naturally do that. That's why our parents, you know, there is a Paracelsus who said that let medicine be thy food. You know, so when you watch our forefathers, I was having a discussion yesterday actually with one of the Royal Majesties, the Royal Fathers. When our forefathers, our food was the medicine. That's why when you eat a lot of bitter leaf is known to help you have brilliant, you know, help your knowledge, if you're like intellect, it sharpens your intellect. You know, it helps with, it helps also with taking care of certain diseases. Like many other things that we eat, that's why we encourage people to go natural. Go natural. Enough of this processed crap. Enough because they come in with cancer and what have you.
If you go down to the localities, you see that most of our people respond to even face mask as our drivers do to seatbelt. They think is for road safety seatbelt, and then COVID protective cover for the commissioner. You know, so what is your ministry doing to make them take this as real and then respond accordingly? Then secondly, please, you see, about cure. There seems to be a contradiction between that COVID doesn't have cure yet, and then the records of people discharged, people who had the attack. How do you reconcile these two contradictions seemingly?
We've done all we can, and we can never say that we've done enough. We just keep on trying to exert that compliance for our people. But there's also a background to why we see some things we see. There is an NOI poll. The NOI, you know NOI poll, right? Ngozi Okonjo-Iweala poll. It's a national poll, and it's being cited by the international community. So they looked at the level of doubt about whether COVID-19 is real or not, you know, in the country. It was a geopolitical zones poll conducted 2 months ago, okay? And guess the geopolitical zone that came out the highest as being the most doubtful, South-South, followed by Southeast, okay? So, and when you see the certain responses among the people, you understand. But that being said, this doesn't go. This goes to say that some of the things you notice might be inborn. But I will still encourage and praise a number of people, a lot of people that comply to these rules. Let's look at the positive and not the negative. A lot of attitudes have changed in the state. Look around here. Is everybody wearing a face mask? Yes, we are. So things have changed. Are we observing social distancing? Yes, we are. Are we not in the Anambra? That should be the narrative. You know, that should be the narrative. But we also look at the what has the government done? Did we just sit back and say, okay, let's just go on? No, we don't do that. We keep on saying it, knowing that our people need to be convinced before they believe. They need to put their finger in the hands, in the wound, before they believe. You know, so we keep on doing that. So that leads to one of the things that the way we organized the thematic areas, community mobilization and sensitization in the state COVID-19 action team. So we do risk communication. Risk communication is key in the fight. It's a strategy where you get to the grassroots, get to people, communicate to them. They need to understand this is what is going on, this is real, this is what you need to do. Risk communication. Now, one of the things the government has also done with respect to enforcement is to back it up with a law. We have the state's COVID-19 prevention law, spread of COVID-19 prevention law, okay? And this shows His Excellency's seriousness about making people comply with the COVID-19 rules. And as a ministry, one thing we've also done is we go out there on enforcement drive. Just last week, as we would do every week, we have 5 epicenters in the state. With 5 centers, we have high transmission in the state. Oka South is one of them. Okay, so we visited popular stores like Ruban. We visited a few other popular businesses in the state. We go there. We go with our chat brigade. We go in there. We talk to people. We talk to the management. We talk to the security men at the entrance. We try to make them understand that nobody comes in here without wearing their mask appropriately. Not just wearing a mask. The nose and the mouth must be covered. We didn't like to tell the people came in with face shield. We said, well, not to send the wrong message. Face shields are not okay if there is no mask. You know, it gives an extra layer of protection, but it cannot be allowed alone. We went further to establish on their checkout counters the stickers that will help them observe social distancing while checking out. And we told the checkout cashiers, don't serve these people if they don't stand in line the way they should stand in line. So these are things we are doing. And also His Excellency has directed that we discuss with religious leaders and plead with them to form COVID-19 task force in the churches. So the church members, the parishes, we come together and say, okay, we need 1, 2, 3, 4. Help us make sure that nobody in this church is violating the rules. So it doesn't seem as if we are giving them a prescriptive stuff. It should come from them. They should encourage them to do those things. So we understand that there are violators out there. And then also we've gone to the market. Every market had COVID-19 task force established. We trained them. We taught them on what they need to do. Get intramural thermometers, get hand wash areas, and have people wear their masks. Don't allow them to market them, then wear the mask. So all these things are there. Ours is just to move around and make sure. And there's the mobile court that has been approved by His Excellency to establish. So we have a bunch of things to make sure that people comply. Now, we need to understand this virus when we talk about cure. Now, we have viruses, some viruses, and most viruses will run their course. When you say you have a viral element, a number of them will run their course and go away. Not all. HIV will not run its course and go away. Okay? So I don't want to confuse. But with respect to most respiratory viruses, they run their course, they either allow you to live or they kill you. So what we try to do is, based on studies, we've seen a lot of studies, like I said, we all went back to medical school with COVID-19. So we read it off. We understand that when the virus goes into the system, through either the conjunctiva, the nostrils, or the mouth, when it hits the respiratory tract, it attaches to a particular receptor. We know the name of that receptor. So when you are now developing a way to counter this virus, you start with mitigation. What makes you not allow it to even gain entrance? That is the first step. Okay? So you can actually do that through avoidance. That's social distancing, or not going to public gatherings. Okay? The second one is wearing a mask. That is appropriate. That will prevent that microbe from gaining access into the system. Now, let's say, unfortunately, it has gained access into the system because you violated the rules, or because maybe you didn't violate the rules, but something happened. Okay? If it comes to the system and then wants to settle in the lungs, there are cells, receptors that you attach to. It's just like when you come to the house. There's only a door. You get access into your house through a particular door, right? Unless you're a magician, you can access through the walls. Yeah, so you have to go through the door. So we know the name of that door that the virus attaches to is a receptor, that particular receptor. So people have developed medications to hit the receptor. And then after entering the door, it unpacks. It has an envelope, it removes everything and then goes to work, enters the nucleus and takes over the cells, you know. So you can stop it at the point where it wants to unpack, stop it from unpacking. So you can stop it from either getting access into the wall or from unpacking or from taking over the cells to do its thing, to replicate. So things have been developed in all those stages, or being developed. Now we understand that some medications actually that have been around, that when you take them, quite early in the game, they might disrupt that attachment or that early preparation to multiply, you know. So those medications might help. Now some other medications will just help with your symptoms. You're having a fever, you take it, okay, helps calm down the fever. You take this one, it helps that. So a number of things that developed was to help symptomatic management. So it runs this course, you can reduce your symptoms until you get better. Now we know some medication approach that actually will give you cure, you know. So when you say cure, you have to say it with, it has to be measured in saying that. Because the ones we have around here, we cannot really say that it cures, but we know that the people eventually become negative or they're no longer effective. And there are medications that we use that will help manage that cause, and also will help us decrease adverse outcome, which is what we notice in the States. If we start those medications early enough, people don't turn the curve, they don't start heading south. But if we started late, it becomes a fight between the rock and the hard place.
Okay, Honorable Commissioner, a quick one. People want to know, what is the actual cost for testing?
In Anambra State, in the government facilities, is free and remains free. So the actual cost for testing a patient that walks into the hospital, not what it costs the government, because that is never free. But the individual going to be tested, the actual cost for the individual is 0 naira and 0 kobo.
With respect to the when this administration took off, what's the status of AMAC in terms of accreditation? There were controversy about some equipment there and there. As you give clarifications, we know the ones that are relevant to what we're doing. Then the other thing we are concerned about is there is the approach of this government to healthcare on 3 levels. With respect to tertiary, General Hospital, the secondary level, what is the status of those General Hospital, especially the selected General Hospital in the senatorial zones which designated for equipment in nature, and I think it's a blood or something like that. We would like to know.
So with respect to AMACO, by the time this government came in, remember, you really have to, if we put this in perspective, doctors were on strike for about 13 to 14 months. You know, it did a lot of harm to the healthcare system. That was the morale for healthcare providers in the States was at its ebb. Okay, but by the time the government of Chief Dr. Obiano, His Excellency, started, you cannot achieve the vision for health that he laid out. You cannot achieve those 24 points agenda and the blueprint. You cannot truly make health an enabler in his economic will of development if you do not address certain key issues in health. So, Chukwemeko Teaching Hospital was actually I would say, only tertiary hospital. But you have the psychiatric hospital, which is specialist, so actually that can qualify as a tertiary hospital too. Now, they were not accredited for a lot of things. So, what the government has achieved, one, is that they got accreditation for their 4th MBBS students. What it means is that this 4th year student that has been there can actually take 4th MBBS. That's the certification exam for medical students. Got accreditation for the 5th MBBS, which is a final MBBS, final certification exam for medical students. You know, then got accreditation for training in certain residencies like pediatrics, ops and gyne, that's for and gynecology, and community medicine. You know, and a number of other key accreditation in the nursing schools like in Paul, that's not like AMACO, but AMACO is actually now overseeing those areas. You know, there's also a bunch of accreditations by the government School of Health Technology, Obosido, that's not AMACO, but it's important to mention that because when you discuss the 6 building blocks for health, you discuss service delivery, you discuss access to care. So in service delivery, if I go to a hospital and I don't have the services I need, what is the essence of going to a hospital? The doctor can see, doctor is not a magician, he cannot see things that are below the skin without some special equipment if the condition demands for that. So the School of Health and Technology, we train the supporting staff for certain medical services. The X-ray technicians, the pharmacy technicians, and a whole bunch of them, about 7 groups. So that school have garnered a lot of accreditations in this administration. Now going to Amaku with respect to equipment and their diagnostic capability. So the only thing that was in Amaku as of that point in time was a beat up X-ray machine, analog machine. Really couldn't do much. So if you need to get a high level ultrasound, you have to go out. If you need to get an X-ray deployed by a digital machine, you have to go out. If you need to get a CAT scan or any of those, you have to go out. At a point, the government actually observed that a few things that were procured there were never installed. Some key equipment, and they were left to be messed up by the elements. And it's one of those things you observe, and you really you're not happy about it. So the government went into kicking action to evaluate and see are there things we can salvage, and then what can we do? So the State Directive is actually this is a teaching hospital. It should have the ability to diagnose complicated diseases and has the ability to also train residents. So you cannot train if you don't have the equipment to do that. So as we speak, Amako, in the next few days or next few weeks, the imaging pavilion is set to perform a 64-slide CT. That should be the highest in the state. And what is it mean? So the 64-slide CAT scan is a machine that is a donut. It's a big donut, with a bunch of X-rays. But it cuts the body like in 10 slides, the 64 slides. That's what they call that. You have like 8 slides, 16 slides, 32 slides, 64 slides, 120 slides. So what it does is actually, if you have just think of a patient that comes with chest pain, and you're evaluating that person, let's say the person traveled from the US, flew for like 16 hours before getting to Nigeria, lands Oka, and touches his chest. Chest is sudden. First thought to any doctor in the emergency room will be pulmonary embolism. Maybe they had a blood clot because they stationary for a while. So how do you diagnose that? You need a CAT scan of that capacity with IV contrast to pick that in the lungs. And this is a disease that can drop you instantly. So if you're able to diagnose that, you start the medication, the person leaves. The person has seen a bunch of those in my career. So you need such a machine in such a teaching hospital. You have also the ability, that machine has the ability to, if you do coronary cuts on the chest with a patient that has coronary artery disease, which is the most common reason why people have cardiac arrest. Now, that machine will be able to cut those slices and actually tell you that we have calcium deposits in so and so vessels in the lung, in the chest. Somebody comes in with worst headache of their life. We sometimes call that caribourism, worst headache of their life, and he goes in there, and within 10 minutes you get a CAT scan of the head. They have a bleed in the brain, subarachnoid hemorrhage. So we have neurologists, neurosurgeons in this town that we know what to do, but you have to diagnose before you can intervene. He's been having headache every day for the past 2 months. Maybe he thinks it's because of stress or because the economy is biting. And he comes to the emergency room and I see him and say, headache, okay, I look at a few things, do a few evaluation. You get a CAT scan, has a small tumor growing in the brain. So you pick it up early, maybe you can intervene. If you don't pick it up early, you don't know what's going on. Eventually the person dies. Same with a lot of cancers that are present in this society. So you can scan the chest for chest pain and you notice that there's a tumor in the lungs. And it might be early enough that you can intervene. Versus, because you don't have a CAT scan, the person presents after like 10 months, when he's now cachectic, lost weight, coughing up stuff, difficulty in breathing, and we wait for anywhere that could go. So those are that is why we actually have that machine, and I'm super excited that in the next few weeks that machine will start working. This was procured by this administration, installed by this administration, and compared to what the other time they got something like that, it was never installed. And that one was by 2 grades, a lower capacity machine. That was a 16 slides. So we went above 16, 32, 64. What you have there is what I use in my place in Texas. So same machine. So 10 or the other thing there is a memo machine. So have a few equipment in there. The station has been restored. The memo is being restored. So it's a pavilion. It's going to be an imaging pavilion. And the plan for His Excellency is to get more. So we'll be able to put a digital angio, a mobile angio, in the same place we have the mobile X-ray machine, digital X-ray machine. You know, so people can do, you don't need to go to outside facilities to do stuff anymore. So we can truly have that training we need for our resident doctors, so that doctors will really be proud to stay in the environment and practice medicine, and not practicing guesswork.
With all what you explained, what is the status of the welfare of the AMAC?
Resident doctors?
Yes. You know, there's always this restiveness. They are going on strike this day, and patients have borne the brunt because we've had cases like that.
It's good for us to also appreciate the effort the government has made with respect to the human personnel for health, the health workforce. Actually, another pillar of our healthcare system. Now, going back to how it was before this government started, we discussed how doctors were at home for 13 to 14 months. We lost a lot of manpower, a lot. They left the shores of this country, some went to other states, never to return, and we faced with the dearth of doctors and other healthcare providers. And the hospitals were abandoned, secondary healthcare system, you know. So, Ramako, when the things we noticed actually, we kept them, we started somewhere, you know, and they've been going home and going back. So this government actually is the first to actually improve, put them on the commerce salary, their salary scale, the acceptable salary scale, or structure rather, and got them up to a scale that is more than like 30% of what they were, where they were before now, is on record. Because the administration got serious with capacity building, with training, you have to think of resources too, to sustain these things. And what we have done as a state, His Excellency graciously approved for us to go into negotiation with the group, and we came out with that good increment, allowing them to stay on a structure that others are in on other states, you know, and also coming up in scale. With the intention, ultimately, we got up to 70%, so then we're actually at 40%. We got up to 70%, with the goal actually and the structure directive to the CMDs, you can always hit 100% based on what you're generating in the place. And that is why it becomes important also that we increase their diagnostic ability. So because also this is not just, it helps us also in their revenue generation. In as much as the key aspect of what we're doing there is to save lives and to train residents. But also if they don't have those ability to make those diagnoses, those services will be provided by an outsider or not provided if it's not available in the state. And they will still pay for it. So there it will be at a highly discounted rate, and it will still be available and save our people. Then in the state, at the state level, our doctors in civil service, they've not had it that good. We had restiveness also, and we appreciate the fact that they have tried. And the Excellency graciously also approved that we also work on their salary structure, put them on the right structure, and got their scale up to 70%. Never happened before here. So, and that just happened a few months ago. So I think with this administration, and going forward after this administration, the state, the human resources in health, we continue to improve, and the welfare package will continue to improve. As a matter of fact, too, the hazard allowance that they're paying the doctors, and they didn't even mention it. Those are service, and when we presented, the SSC says no, increase the hazard allowance by 100%, and we did that, you know. So they're enjoying a 100% increment in the hazard allowance. So we have a lot of high points. And then the other big thing that's happened there, so now you actually ask the question about human resources for health. A lot of recruitment has happened over the past since 2014, but it can never be enough because, I mean, across Africa, we understand that the doctor-patient ratio and the nurse-patient ratio is not at deplorable, it's actually at a deplorable rate. But that being said, we are working hard to make sure we meet that ratio. You know, that's the mandate, the directive from His Excellency. The ministry has set up for the first time what we call a Human Resources for Health digital database through the support of His Excellency and partners. You know, so that's the first time that's happened. So all these things are achievements that will leave a stronger structure by the time this administration is done. Now, with respect to the general hospitals, now we had about 34 general hospitals by the time this administration started. Now, the state of most of the things in the hospital were very deplorable. So, His Excellency, the goal then was to ask a team to go and visit all these hospitals and come up with a template and a design, a prototype, what we need to do to make them to be world class, at least serve the role of a secondary healthcare system. But they did that work, came back, made a report, and then we went ahead to pick 3 hospitals, one per senatorial zone, to make them specialist hospital, bring them to a class where you can get most things that you need to get in a general hospital or specialist hospital. So the 3 hospitals that were earmarked for this was Onitsha General Hospital, General Hospital Enugu, and General Hospital Obiano. And contracts were awarded and work has been in progress. Onitsha is complete, but we're still putting more capacity in that hospital. That is why it was a natural choice for an isolation or protective care center. Even though when we went there, we had to do some more because that concept was not there. We did a lot of work to get that happen within 2 months, you know. And it's still it's on a helipad. So all this infrastructure that's there, they're going to add more things to make it become a state-of-the-art healthcare facility, both in structure and in the facility, the equipment and manpower. Now, Enugu is experiencing the same trend, and I bet you in the next few months you see ramping up of work in that hospital before first quarter of next year. We should have actually been done with that work with equipment. Same thing also is happening with Ekulobia. So those are the 3 key facilities. The way we want to look at healthcare in the state actually is this. Anambra State as a state, looking at our footprint in the map of Nigeria, is not too big based on landmass. So if somebody can leave this state and go to India for care, if I have one good hospital, any part of the state, won't they go there? They go to that place to access care. That's the mindset. You know, so what we have seen as a state way back is having multiplicity of hospital structures across. So it becomes impracticable to really meet up all those needs. So but you can actually start nesting capacity in particular field of medicine in certain hospitals in the state. So you can increase the specialty outlook of this hospital and then also improve on the services that they're able to deliver. So you can create the reverse medical tourism that we hope to get to. So people can actually come from other states to these hospitals for their care. That is the target of the administration.
Let's take a brief look at the primary health centers. Using the one in my town as a case study. I come from Nimo. I know that the challenges they have center mainly on non-availability of some drugs, power supply, and then at a point paying the security man who was looking after the place became a problem. The community got involved at a point. So how is your ministry coping with the problems associated with the running of the over 300 primary health centers in the state? Thank you.
As a matter of fact, actually, Anambra State has about 650 primary healthcare centers. Remember, the healthcare system in the country is tiered. Now, with respect to the primary healthcare centers, healthcare system, way back around 2012, a lot of studies came out that discussed making the primary health care system a bit independent from the Ministry of Health, like bringing a lot of programs under them to put them under one roof. So the concept of having primary health care under one roof came up. And by the time we came in 2014, the readiness of the state to get to PHC under one roof was very poor. We were actually at about 7% / non-existent, compared to some other states that actually have achieved that status. So His Excellency went ahead to form that board, the Primary Care Development Agency, as an independent, with Minister of Health having oversight function, supervisory role over what happens there. And we tried to get a lot of things in place. And eventually, within a year or two, we went from 7% to 80-something% of state of readiness. But that being said, not just that, there are a lot of other things that has happened. When you look at things like infant mortality rates, maternal mortality rates, under 5 mortality rates, all these things reflect on how good your primary health care system is. And those rates in the state improved remarkably since this was done. That is one. And two, you look at our vaccination penetration across the state, we've done very well in immunization. And this is testimony to how good your PSC system has worked. But now looking at infrastructure, yes, there is, we've had a lot of problem with infrastructure. But what this government has done is to gradually identify and fix the poor infrastructure in different areas in the PHCs. Like the last set of job we did was to look at 63. We picked 21 per senatorial zone. And they were upgraded. They were given tricycle ambulances, and people were trained. And very soon we'll be looking at the next set of 63 and putting another 63 before the admission winds down. But the goal is to get things right. Now that being said, we also have a system, the Basic Health Care Provision Fund, which is a component of the National Health Act of 2014. So the Basic Health Care Provision Fund will feed the primary health care system, while the part of it will feed the state health insurance scheme, which one of the big achievements of this administration is a key aspect of the achievement of this administration. Now, we needed to be ready. We need to do a bunch of things for us to be ready to access that fund from the federal government. As Excellency gave all the support, including warehousing 100 million naira at the point to make sure that we attracted the big fund. So by the next month, we start attracting that fund. And when this fund comes, the state doesn't manage the fund. Even the agency doesn't. This fund goes straight to the primary health care center. So that health care center in Nimo will get a particular amount of money on a monthly basis. And not just that one coming from the State Primary Health Care Development Agency. They also get some amount of money from the Anambra State Health Insurance Agency and the National Health Insurance Scheme. The one supervising that. And this is all coming from Abuja. The one coming from the Healthcare Agency is based on the patients that they treated in Nimo. And this could be Nimo residents that don't have access, they don't have any money, that are poor, that don't have any access to care. They go to that healthcare center, they get treated, and the healthcare center administration will submit that bill to the Anambra State Insurance Agency and National Health Insurance Scheme representative of Anambra State. And within a few weeks, they get paid from that money. So it's a new dawn for our PHCs. So this money coming to the healthcare centers will be managed by the WDC and the officer in charge. Who are the WDC members? The WDC, or World Development Committee, is made up of people from Nimo, indigenes. The only person there that's not an indigene in that management arm is the officer in charge. Most times, this officer in charge is the person, the provider, the healthcare provider that's in the leadership of the PHC. So that individual's job is to provide care. So that person becomes the secretary of the WDC. And together with the indigene from Nimo, the detailed chairman, they manage the fund coming there. So that individual, the OIC might say, when that money comes monthly, she might say, or he might say, oh, we need to buy medications. And the other members of the WDC will say, no, that roof is leaking, we need to fix it. Or we think we need a solar this time, and we have somebody that can do that very cheap. And because it's democratic, they will be the ones to prevail on the OIC, and that job will be done. And remember, money comes every month or every quarter, depending on how it's structured. And then that primary health care center now will start seeing more patients and keep on enrolling them to the social health insurance scheme and keep on getting more money that's trickling down from the federal government. We as a ministry cannot even intervene in that matter. So it's a new dawn, and we are happy. I'm very grateful to His Excellency for doing the necessary things that need to be done to qualify the state to be able to access this fund. So that is where this is going. So I will actually ask everybody here, because we all come from a political world, to pay attention to our PHC. But remember, it's not every PHC among the 650 that enjoys this. Every political ward will present only one PHC, Pro Care Center. There are some political wards that have more than 2 or 3. Then it's only one of those PHCs that will enjoy this. So we have about 326, actually 330 primary care centers that will access this fund. And the fund is already here. It came in this month. So that is where we are. So we are hopeful. But that being said, His Excellency is not also sitting back on putting more fund in infrastructure repair for those that are already dilapidated. So we're asking for Anambrarians at the grassroots to pay more attention to their healthcare centers and also to take ownership. It's very important. We've been to healthcare centers where they want to bring, they don't secure the place. People will come in there and vandalize the healthcare center. And we say this belongs to the community. They're going to have to come together to protect what is theirs and take ownership. It's very important.
Yearly, we always record numbers of deaths emanating from cholera on the upper north. And I know cholera has to do with intake of impure water and others. So what is the ministry doing to construct portable boreholes in these hard-to-reach areas like Anambra West? And again, when you award these contracts, is there a monitoring team to make sure that these projects are executed? Because oftentimes the contracts are awarded without the contractors doing the project.
It's one of those endemic diseases that we have a certain part of the year. So a lot of work needs to be done, and a lot has been done, but we need to do more work. And the ministry, as we are now, we have our structure. Our rapid response team is set up to detect. But before detection, we want also mitigation. Let it not even happen. And that state of mitigation is where we talk about having potable water, access to water, and simple about hygiene. Okay, very important. Now, we have the WASH program, a UNICEF program. So we cannot achieve these things with as Ministry of Health alone. It has to be teamwork between utility, environment, health. Actually, sometimes agriculture too. So there are places that intervention has been done, but this is a continuous process, and we keep on pushing, because we know at the end of the day it ends up in health. And not just social, but for those that develop this disease, mothers are being taught to be able to identify dehydration, because sometimes not the cholera that kills, it's the complications, especially dehydration. So if a mother is able to identify mild, moderate, or severe dehydration, which is teachable, and we're already doing that, then identify the interventions to make at the mild and moderate level, the sugar salt solution and what have you. That will help us a lot before they get access to healthcare. Also identify that now I need to get to the primary health care center. And every political ward, like you said, have a primary health care center with trained personnel who knows how to intervene in this disease. So when it comes to education, now that is happening too with the Basic Health Protection Fund. We'll be setting up across the state what we call Community Health Influencer Program. It's cheap. So at the end of the day, maybe the next few months or getting to next year, we have about 10 people per community whose job it is to keep on educating residents, the grassroots residents, on certain things like this cholera. This is what to expect, this is what you need to do to avoid this. In areas during the flood this season where it's unavoidable, then we are ready to respond to take care of things and deal with it.
On the 8th of August 2019, we commissioned a gigantic outfit within the Chukwuemeka University Teaching Hospital, the Anambra Oxygen Plant Limited. I don't know, what is the success story today? What is the production capacity of that oxygen plant? And as at today, compared to what we were told that will be coming out from that oxygen plant, from that commissioning.
Now, the oxygen plant, it still shows the visionary leadership of His Excellency. When this plant was being commissioned August 8 last year, which I coincided with his birthday, so nobody knew that COVID was coming down the road, you know. So, and when COVID hit, everybody learned about oxygen. It became the topical discussion because it's a disease that hits the respiratory system and takes out the ability of your lungs to exchange oxygen with air. So it became very important. So that infrastructure, the machine was set to supply oxygen to any part of the southeast and beyond. It has that capacity, okay, as built. It has the biggest capacity when it comes to medicinal oxygen plants in the country. So, and he has done a lot of work since then. His Excellency mandated that we should give oxygen to public hospitals free since this started, and we've been doing that. Then to private facilities at a discounted rate, and they've been coming to get oxygen. I'm yet to get any complaint, because usually if there's a problem, they call the Ministry of Health. They don't even talk to the plant. Now, I'm yet to, all I get is accolades from them that your plant is doing well. It's a visionary investment, and we all look up to His Excellency and say thank you for making a visionary investment. It's a mark of leadership. So, with respect to that, is a big winner. And if this is the last question, I use the opportunity to express my gratitude to members of the health team. You know, we start with the God, then His Excellency, and the health team, particularly Asha. Like I mentioned, Anambra State Insurance NJC is one of the shining kids on the block in what we do. Then the Executive Secretary of Anambra State Blanket Development Agency, the MD of the oxygen plant, the medical directors, the CMD of Amako, the members of the rapid response team, they're both all the directors in the ministry. Since COVID, since that first started, nobody has taken a break in Ministry of Health. I know that when they had a lockdown, we were the only ministry that was open. People have been coming to work since then, including nights and weekends. Like I told you last night, I left on the Children's Hospital like 1 a.m. People were there working. They left there like 9 a.m. this morning. So that's how it's been set up. So the members of the Ministry of Health, rapid response team, without them, the ministry and the state will not achieve what we've achieved. And also the other supporting ministries, especially the media. You guys have been so marvelous. I mean, you've helped to tell our stories. You've helped to talk to people when there is doubt, to calm people down when they're when they're anxious. It's very important in the work you guys do. I remember the doubts, you know, you have to encourage them and tell them, have faith, we are moving forward. And that also being said, I remember in this case, we were all there digging it out, you know. So basically, you guys have been quite supportive and taking bullets, both on the social media and on the print media. So I thank you. And above all, we express our gratitude to every member of the other ministries that have been quite supportive. I can't start mentioning them, but a lot of them have been quite supportive. And the principal officer of the government. There is a vision, and that vision was a well thought out vision, and this administration will achieve those visions before the dawn of this administration. Thank you.